Hi, everyone. Welcome to the Midlife Wellness NP. My name's Kim Heifner. I'm a board certified family nurse practitioner. I choose to specialize in the care of the midlife and menopausal woman, and I'm the host of this podcast. So, welcome. Well, as a trusted healthcare provider, the pharmacist's expertise is invaluable when it comes to navigating the complexities of hormone therapy. And as we know, hormones are not simple, and in fact, they are quite complicated. My next guest has been a licensed hormone pharmacist for over 25 years. He is a leading authority on integrative hormone health and hormone therapy. He is a trusted resource for healthcare providers like myself all over the US, Canada, and the UK. Through his popular YouTube channel, Simple Hormones, he has over 840,000 views, and he has connected many of those viewers with licensed hormone specialists. And through his digital courses, he has also educated and empowered thousands of women, helping them to achieve the life-transforming power of optimal hormones. His content is clear and concise, making it easy for anyone to understand, even without a medical background. I am excited to welcome to the Midlife Wellness NP, Stephen Goldring. Hi, Steve. Welcome to the podcast. Happy to have you.
Thank you so much, Kim. It's great to be here. Excited to talk about hormones, like always.
Yeah, me too. I'm excited I found you. And I will tell you that Pharmacist, I thought when I found you, I'm like, how great is this? I use Pharmacist constantly. You guys are so smart. My daughter's a pharmacist, and I thought, who better to talk to about hormones than you? So I am happy to have you.
Thank you so much.
Yeah. So first question though, how did you end up involved in hormone therapy and specializing in menopause hormone therapy?
Well, I've been a compounding pharmacist. I've been a pharmacist for a long time and a compounding pharmacist for probably the last 20, 25 years. Maybe I can't even remember how long. So compounding pharmacy, as you're probably aware, involves a lot of compounding of hormone replacement therapy for a lot of women in menopause. That's probably 80% of the patients that come to a compounding pharmacy. And so I spent a lot of my time speaking over the counter, teaching patients about hormones, both men and women, men to some extent. Over time, eventually, so I found myself in, 2015, I was working in a little mom and pop pharmacy in Wilsonville, Oregon. And I was talking to women in menopause over the counter, and I would have this, was supposed to be like a 5-minute conversation counseling the patient, and then you move on to the next one. But they would have these questions, and I would have answers, and they would have more and more questions. And pretty soon I realized that 5 minutes was stretching out to 10, 15, 20 minutes, which is fine. I loved talking about hormones with these women and answering all their questions, and they just were like, oh, so relieved to learn what they needed to learn.
Right.
But what I realized is, there's another woman standing in line right after that woman that I just spent 20 minutes with. And then there's a third woman standing in line after that one. And so this is going to get to be a bit of a problem. So I started really thinking about how can I move from teaching one-to-one toward teaching one-to-many and helping to answer these women's questions. The other thing that I discovered in talking to women one-on-one is basically none of them knew anything about hormones. All they knew was they were terrified and they were worried about breast cancer, and everything that they read and heard and their friends told them was scary. And so that was all they knew. And they didn't really know anything else. They didn't know what estradiol was or progesterone. They didn't really know what they were taking. And so they needed a lot of, first of all, they needed empathy, but they also needed evidence. They needed reassurance, but also the truth about what they were experiencing. And so, long story short, that was 2015, and here we are 9 years later, and I've been developing this idea of teaching women, especially women in menopause, as well as other types of patients, all about the benefits of optimal hormones. I have a really good friend. I meet him for coffee every Thursday, and he's a gregarious kind of German guy, and he always calls me, oh, this is my friend Steve, the menopause guy. Oh, that's so funny. He's just mocking me. Which, of course, I'm like, yeah, that's me, menopause guy.
Yeah.
So that's kind of my long story short about how I became the menopause man.
Yeah. Yeah. Well, we're thrilled because we need you and women need education, and you're doing a great job. I love your channel, Simple Hormones. It's how I found you. So happy to share that with everybody.
Thank you.
Um, One of your videos, which I think we'll start with, is why do you believe women have been lied to about menopausal hormone therapy?
There have been that title from that video came from an article in the New York Times Sunday magazine. I think it was February 5th of 2023. And it was all about the Women's Health Initiative and the Women's Health Initiative being seen as gospel truth about hormones. And as many people may know, or some of your viewers may not know, back in 2000, somewhere in 2000, 2001, the Women's Health Initiative, basically the largest study ever conducted, most expensive clinical trial ever conducted, was abruptly stopped because the researchers were freaking out over a perceived increased risk of breast cancer. And so this study has had a massive impact of essentially women at the time were taking lots and lots of hormones for menopause that were working great, but they started flushing them down the toilet, calling their doctors super upset. They just stopped taking hormones because of what happened in the news, in the media, which basically took this the study and overblew the results by 1,000 times. Now, from my perspective, I've read that study very, very carefully. And what happens if you read the study, you can see that it says there was a slight increased risk of breast cancer in women who took hormones. But that risk was not statistically significant, which means it was so small that it could have just been by chance. And if you look at the absolute numbers, it just wasn't very many women got additional cases of breast cancer. One of the health influencers that I follow, Dr. Peter Attia, calls it the biggest screw up in the healthcare in the last 25 years. This whole thing of throwing out hormone replacement therapy because of misinterpretation of this study. And so this study has amazing legs. It's stuck around, influencing doctors to this day, who basically tell patients, well, the Women's Health Initiative study says that you're going to get more breast cancer if you take hormones. But they haven't read the study, or they would realize it's not really in there.
Yeah.
And so to this day, one of the things that I'm fighting against constantly is women email me just about every single day saying, my doctor said I'm going to get more breast cancer. I'm more likely to get breast cancer if I take hormones, so he won't give them to me. That's where women have been lied to and completely misled, because that's simply not true, especially since now we have a whole different set of hormones that behaves quite more neatly than the hormones that were taken back in 2000. So that's a long answer, but the answer is women have been lied to primarily because of the Women's Health Initiative and the idea that they're going to have increased risk of breast cancer, as well as heart disease and stroke and blood clots and a bunch of other things. But the data, the actual studies, don't show that. So that's the problem. There's a disconnect between what people think and what the truth is.
That's right. That's right. Why don't you talk a little bit about, I cannot believe like that is constantly the quoted studies, but what did they get wrong? Why were those studies so flawed in the first place?
Well, there were multiple reasons why the Women's Health Initiative really needs to be taken with a grain of salt. One is one I've already mentioned, the statistical significance issue.
Right.
The other, the title of the Women's Health Initiative, I can't remember the whole title, but it starts out with HRT among healthy postmenopausal women.
Right.
If you look very carefully at the healthy postmenopausal women part, you realize two things about the women that were looked at in that particular study. We call it the WHI, Women's Health Initiative. The women in that study were on average 12 years past menopause. They were on average about 63. The average age of menopause is 51. That is a very long time for them to go without hormones. And what that what that does, we know now that what that does is that 12-year time period is a lot of time for heart disease to build up, for osteoporosis to build up, for a lot of disease to get a lot worse. Because as we now know, when you lose your hormones at age 51, you start opening yourself up to a bunch of disease issues. The rate of heart disease in women at age 50 is actually much lower than the rate for men. By the time they get to 60, they haven't had hormones for about 9 or 10 years. The rate of heart disease is about the same between men and women. The difference is estradiol in that time period. The loss of estradiol means increased risk of cardiovascular disease. But the problem in the WHI is we looked at all these older women. The second problem is that they're called healthy postmenopausal women, but when you look at the actual, there's a chart in the study that shows what were these actual women like. Something like 40% had diabetes, and a whole bunch had hypertension, high blood pressure. A lot of them were either current or past smokers. The average weight among these put most of them into the heavily overweight or obese category for almost all of them. And so most of them had cholesterol issues, and a lot of them were taking statins for cholesterol. So to call this group healthy postmenopausal women is a big stretch. And so what we're doing is we're making this giant assumption in the title, healthy, but then we're saying, well, they developed all these diseases. Well, wait a minute. They weren't healthy to begin with, and they're developing these diseases that they may have already had to begin with. So it really is a big question in my mind about the validity of the whole study. Obviously, this is an important study. We've learned a lot. There's a lot of kind of sub-arms to the study that can be really helpful. There's arms about exercise, and there's arms about calcium, and there's arms about all kinds of different things. There's mountains of data from this study, which are really important, but we have to really understand the details about it and recognize that it does not say that women are likely to get more breast cancer by taking hormones. It actually says the opposite, that it's not really, it's about the same with or without hormones. So I could easily get on a long-winded soapbox about the WHI, which I think I already have.
Well, it's been a huge disservice to women. And think about what happened when they all stopped their hormones. Just the suffering and the lives that are maybe lost just from stopping them. So,
there's another study by Dr. Philip Sorrell. I believe he's from Yale, and he looked at women. He was looking only at women who had had hysterectomies. And he was kind of comparing before the WHI with after the WHI, and essentially a vast majority of women who had had hysterectomies did not get hormones after the WHI. And what he calculated is about 100,000 women died because they didn't get hormones. And this is it's a fascinating study, but he basically is calculating, it's an estimate, of course, but that's a huge number of people who, because they didn't get hormones, they developed these diseases, long-term disease problems, and they died early because basically as a result of the Women's Health Initiative.
Yeah. Yeah, that is so sad. When you talk about estrogen and the differences, I found it interesting as I started digging into hormones in general that estrogen is really a class of hormones and different ones are more, pregnancy. So maybe you just run through that, and progesterone, just because maybe somebody doesn't really understand all of that and why those are so beneficial to us. Right.
Well, a lot of people think of the word estrogen and they kind of think of it as a monolithic hormone. And basically, estrogens all behave in a similar way. Humans make really 3 primary estrogens. They may make more than that, but the 3 that are most kind of prevalent in human females, at least, are estrone, estriol, and estradiol. So it's 1, 2, and no. Estrone is it's also called E1.
Mhm.
Estriol is called E3, and estradiol is called E2. So you can kind of think of them as 1, 2, and 3. Estradiol is really the one that's the most potent, the most powerful. It takes the smallest amount of estradiol to make a difference. The other two have some usefulness, and they've been around for a long time. I would say, in general, probably 80 or 90% of the usefulness of estrogen comes from estradiol, because that's the one that really is the most active.
Mhm.
There's some people who have used estriol, and the reason for that, estriol is very commonly very high during pregnancy,
Mhm.
and there's also some kind of a thin amount of evidence. I don't think it's really robust, but there's some evidence that estriol may be involved in protection against breast cancer. That's relatively old evidence, and it's not a lot of evidence, but that's kind of the reasoning why some doctors and nurse practitioners and PAs will include estriol in some formulations. Estriol can also be effective in a vaginal dosage form to help with vaginal menopause issues.
Mhm.
Estrone has its own set of issues. There seems to be some evidence, and again, it's not super robust, but some evidence that certain metabolites of estrone are involved in the production of breast cancer cells.
Mhm.
I don't know how much stock I put in that, but estrone is probably the least useful of all of the estrogens. Now, one thing to remember is estradiol does get converted into estrone. And so you can't avoid estrone completely, but basically there are 3 different estrogens. The most important one is estradiol. Now, when we talk about progesterone, a lot of people confuse progesterone with another something called a progestin or a progestogen or medroxyprogesterone, because the names all have a progest in them. They kind of sound similar. They can be a little bit confusing. The key thing to remember is that progesterone is exactly the same as the progesterone produced in the human ovary. It's actually produced right after you ovulate by the leftover part of ovulation, which is called the corpus luteum. And progesterone is a hugely important hormone in menopause that a lot of people don't realize. A lot of people think it's a little bit optional, but progesterone can have a major impact on things like sleep and mood and depression and anxiety. Um, there's some subtle nuances about that. The problem that we've experienced, though, in the past is using other progestins that are similar to progesterone, but they're not exactly the same. They just have a tiny little chemical tweak to them. If you look at the structure, you can see the structure and you can say, well, they look pretty much the same. Oh, there's a tiny little difference. There's a hydroxy group there, and you can barely tell. But that little tiny change makes a huge difference in how those progestins behave when compared to progesterone. So that's kind of a basic rundown of the 2 primary female hormones, estradiol or estrogen, and then progesterone and progestins.
So progesterone is typically micronized, given orally or vaginally, I think. But I think it's important to realize that what they're using in birth control pills and IUDs are more of the synthetic, not progesterone is not found in any of those products.
Right, right.
And
It really kind of burns me when people use the word progesterone interchangeably with progestins. And I have a lot of respect for Dr. Peter Attia. He's somebody that I follow very closely, but
yeah.
he has multiple times talked about the Mirena IUD as a progesterone IUD. It does not have progesterone in it. It has a progestin. But he said that probably 15 times. It's just like, get it right.
Yeah, yeah, yeah.
A
Well, I think
progesterone is actually requires a very high dose, and you can't get that kind of a dose from an IUD. You can't get enough in an IUD. Go ahead.
yeah, no, no, no. I think going back to those women's health studies, they use synthetic progestins.
Mhm.
So that's what concerns me is that And when they did that arm of the study with just estrogen and they saw the decreased risk of breast cancer, that's why I find it concerning with the combination of using synthetic estrogen and synthetic progestin, that's where that increase and those concerns were founded. So yeah, I love micronized progesterone. I think it's really beneficial for a lot of women. But I will ask you, and you've talked about this, progesterone intolerance. So talk about that a little bit, because it's actually, I've had quite a few women say that they were progesterone intolerant. What does that mean? Why does that happen? And what can you do when what's the option if that's happening?
Yeah, I have run across this actually quite recently. A really good friend of mine and my wife's, we go to church with her. She wanted to talk to me about her menopause issues. And so my wife and our friend and I got together at a coffee shop and we're talking about stuff. And I gave her some recommendations. She started seeing our doctor and it was great. She was doing well. And then she was struggling with sleep. She said she's never been a good sleeper. And so I recommended, well, you should talk to Joe, our doctor, about taking progesterone. Oral progesterone would be the best. It would be the most likely to help with sleep. So she did. And she totally tanked. She said she was feeling awful. She wasn't sleeping well at all, but she was also feeling incredibly anxious and depressed, so depressed that she felt like she wanted to take her life.
Awful.
And this was, and I'm kind of a little bit in shock. But she also told me a little bit more of the story. She said, this reminds me of when I was younger. She's like, I think 51 or something, right at menopause age. She said, when I was younger, I had PMDD, premenstrual dysphoric disorder. And this is exactly how I felt. Every month, about, 8 or 10 days before my period would start, I would just tank. And I felt terrible for my husband because I wanted to kill myself every month. And so I thought, I wonder if there's some kind of a connection between PMDD when you're but long before you go into menopause, and then having progesterone intolerance issues. And I started looking into it, and there's actually a metabolic pathway. I won't go into all the details, but it has to do with GABA A receptors and kind of a metabolite of progesterone that apparently both women with PMDD and women with progesterone intolerance may struggle with how to deal with this metabolite of progesterone. Excuse me. And I think there's a correlation there. I don't have any solid clinical trial that shows me that, but it seems to be hinting. And this is something that I basically discovered on my own. And then I posted a video all about progesterone intolerance, and I got tons of comments and responses and emails all about people's experience with the same thing. And especially this kind of correlation between PMDD when they're 35 years old and then progesterone intolerance when they're 52 years old. It seems to be very much tied together. Now, obviously not 100%, but there seems to be some type of association there, which I found really interesting.
Mm-hmm.
And I actually put out a little kind of informal survey to a lot of the doctors and nurse practitioners that I work with. And I said, what's your experience with progesterone intolerance? And I got probably a half a dozen responses, and most of them said it's relatively rare. Some said 5%, some said 15%, but it's also very real that women who have that, it's a serious issue, and it's nothing to be kind of dismissed. Now, you mentioned what can we do in that situation? And the recommendation that I've received from a lot of these providers that I work with and things that have worked for them primarily have to do with start low and go slow. Okay. And so you would need to use a compounded prescription for progesterone because the only ones that are available are basically 100 milligrams and 200 milligrams. Those are commercially available. Mm-hmm. So a compounding pharmacy could make a 10 milligram progesterone capsule. Mm-hmm. And then you could take 10 milligrams for, let's say, a month or 6 weeks, and then bump up to 2 of them and take 20 milligrams for a month or 6 weeks, and kind of gradually build up, and then kind of find the dose that seems to be the best. You may not be able to get up to a high dose, but that's one approach that has worked for a lot of providers. Now, I have had some other providers who had an interesting idea, and they've used this in the past with some success, and that is they feel like the progesterone dose was actually too low, and that when women were getting these depressive, anxious symptoms, that they needed to do a higher dose. That seems a little risky to me, but some providers have done that kind of thing. But the key, and this is what I recommended in that particular video, is to talk with a provider who has some experience and really knows what to do with progesterone intolerance issues and knows how to handle those unusual situations, 10-15%.
So women who are saying, well, why do we even need progesterone if I don't tolerate it? Maybe talk about why it's so important that we don't leave that one out.
Right. Well, there's actually two different reasons. One reason is progesterone. I think I've alluded to it in the last few minutes. Progesterone does affect a few symptoms of menopause that are basically completely ignored many times. Insomnia. I have talked to so many women in menopause who sleep 2 or 3 or 4 hours every single night for months on end. And women complain about brain fog, and I am 100% convinced that a major contributor to brain fog is sleep deprivation. And these women, can't remember where they put their car or their keys or their kid or their kid's name, or they can't remember to pick their kid up at soccer practice because they just haven't had any sleep and their brain is not working properly. And it's all about the loss of sleep. And besides that set of women who has progesterone intolerance, that 85% who don't, many have said progesterone is a miracle sleeping aid. Progesterone has skyrocketed my ability to sleep. Instead of 2 or 3 hours, I'm sleeping 7 or 8 or 9 and feeling great. And my brain fog is all cleared up. So that one thing is a major reason why women should be taking, whether they have a uterus or not. And that brings up point number 2. Progesterone is given along with estradiol. So estradiol helps with hot flashes and vaginal dryness, and it helps with mood swings and a lot of other issues. When you give estradiol by itself, estradiol naturally, and it does this when you're of childbearing age, it causes a buildup of the lining of the uterus. That's called the endometrium. And so if you just have estradiol, that endometrium, the lining of the uterus, will get thicker and thicker and thicker and thicker and thicker. Eventually it gets so thick that it develops what's called endometrial hyperplasia or endometrial cancer. So it's an extremely dangerous problem that was discovered maybe in the 1970s. But what we've also discovered is progesterone kind of stops that from happening. So it's the kind of balancing act between estradiol causing growth and progesterone kind of tamping it down. So when you have both of them together, it's not really a problem. But if you just take the progesterone out and a woman has a uterus, that's going to continue to grow. Even without a uterus, though, that woman needs that progesterone in order to help, especially with sleep, but also with depression and anxiety are 2 major symptoms that a lot of women really struggle with. And progesterone can really help with those as long as you don't have PMDD and in the past, or progesterone intolerance.
I'm so glad you mentioned that because it's confusing for women, because if you look at the guidelines, it'll say women who have a hysterectomy do not need progesterone, only give estrogen. But then, like you said, like in my experience with my patients, progesterone is a godsend, and it's got so many benefits beyond just uterine protection, like you just talked about. So absolutely
it's
so important.
Gospel truth. It's 100% gospel truth. If you've had a hysterectomy, you don't need progesterone. I have hundreds of women who contact me saying, I had a hysterectomy. I never sleep. What can I do? My doctor says I don't need progesterone. It's like, duh, take progesterone and your problem is solved.
Right. And I would much rather have somebody on progesterone than Ambien or some of those other sleep aids. So definitely a safer choice.
The issue is the misinterpretation of the Women's Health Initiative. And so doctors and nurse practitioners are believing progesterone increases the risk of breast cancer. And that's a double misinterpretation. The first misinterpretation is believing that the Women's Health Initiative said that hormones increase breast cancer. But the second misinterpretation is believing that progesterone is the same as the progestin that was used in the Women's Health Initiative. So both of those are misinterpretations. And it's simply not true that progesterone increases breast cancer risk. And so we might as well give progesterone to help with those severe, serious long-term symptoms.
Right. Have you heard anything or read anything about progesterone associated with like meningiomas, or there was something, I don't know, I read about it, but I don't know if it's a correlation.
I do know that progesterone is a relatively safe hormone, and
Yeah.
it's pretty hard to dig up all that much negative studies
Yeah.
about progesterone.
And I think it was actually, that's another thing to clarify. I think it was actually with progestins. And I think that's so hard for women, especially, I will tell you, when I have patients come to me, they are automatically put on MPA or, medroxyprogesterone. And I'm like, oh, no. Let's switch this over. I mean, just to be on the safe side. But one thing to mention is progesterone is often given in a cream.
Mhm.
But my training said that doesn't necessarily protect your endometrium when given in a cream. Is that your understanding as well?
Yes, I've actually talked to I would guess a half a dozen different providers who have told me kind of their horror stories of getting a new patient who has been on a progesterone cream and estradiol for some length of time, and they get a what's called a transvaginal ultrasound, which is the way you check the lining of the uterus or the endometrium to see how thick it is. And these providers will say, uh-oh, we have a big problem here because the lining of your uterus is really getting out of control. How long have you been on that progesterone cream? Oh, 5 years. And so what they've told me is there are lots of these cases where a patient was on a progesterone cream and the provider who gave it to him wasn't really checking very closely, and that cream did not do a very good job of protecting the lining of the uterus. Now, I don't have anything against progesterone creams in general, but I
Mhm.
will say two things, and that is that the way progesterone works when you take it orally makes it much more effective in helping with sleep and mood. And it also makes it more effective in helping to reduce the overgrowth of the lining of the uterus.
Mhm.
Now, if women are in perimenopause and they haven't gone in menopause yet, or they're not taking estrogen or
Mhm.
that kind of thing, then maybe the creams are fine in that
Mhm.
situation. But for
Mhm.
women in menopause, almost always I recommend an oral form of micronized progesterone. Micronized just refers to the size of the particles and how small it's kind of ground up, because it tends to kind of absorb more effectively when it's really, really tiny.
Yeah, I
But
wanted to bring that up because that's really important. I literally just had that happen with a patient that just recently came to me that was on the cream, and exactly what you just described. So that's why I wanted to bring that up, because I want to make sure women are getting protected with their uterus. Um, so with hormone therapy in general, you did a great job on one of your videos talking about all of the invisible benefits that people may not realize they are receiving with hormone therapy. So maybe we could talk about that. What are the invisible benefits of hormone therapy that people don't even realize is happening for them?
right. Well, a lot of people don't realize that menopause is not just about the symptoms. So the obvious things are, if you're going to have hot flashes without estradiol and you start taking estradiol, those are going to go away. If you get the right dose, they're going to go away in a week, maybe 2 weeks. And a lot of your symptoms are going to either be relieved or, in many cases, eliminated when you get what I call optimal hormone levels. The
Mhm.
invisible benefits, though, of hormone optimization is about reducing your long-term health risks. And there are a number of health problems that you are basically open to because you lose your hormones at menopause. Um, Osteoporosis is probably the first one. Um,
Mhm.
the the loss of bone strength is extremely common, and it happens within about 10 years of menopause. Most women go into menopause, natural menopause, around age 51. And within about 10 years, you lose a lot of your bone density and bone strength. And what a lot of people don't realize is that eventually you could fall and break a wrist, or even worse, you could fall and break a hip. The statistics are that when older people fall and break a hip, 30% of them die within a year out of complications. And then the other 70% end up with less mobility. So if they were walking without any, assistance, then they start using a cane. If they were using a cane, they break a hip, now they're using a walker. If they were using a walker, they break a hip, now they are in a wheelchair. You lose a lot of mobility. And what that says is down the line, we're talking about nursing homes. We're talking about losing your sense of independence, your ability to maintain your home, that kind of thing. So osteoporosis is a huge risk in menopause. And there is one thing that's been proven to be the most effective preventative and the most effective treatment for osteoporosis, and that is optimizing your hormone levels. That's just one of the hidden benefits of optimizing your hormones. The second is prevention of cardiovascular disease. There are a couple of long-term clinical trials that looked at estradiol specifically and its ability to reduce cardiovascular risk. And there are a couple of different ways that those studies looked at that risk. But the bottom line is optimizing your estradiol level, especially if you do it early in menopause, like right after you go into menopause, can have a dramatic impact on whether you get cardiovascular disease or not.
I will say this. When I put patients on hormone therapy, that's what I do, but they go back to their OB and their OB will say, don't put them, just yesterday, well, don't let her put her above 0.25 milligrams. And I'm like, well, is that, that she doesn't, they always say lowest effective dose for the shortest amount of time. So why is that wrong? Why are they getting that wrong? Why are they so, afraid? And they're guiding women, because it was my understanding, and maybe you could help me on this since you're a pharmacist. Back in the women's health study, before they started, when the women were on Premarin, this dose was 0.625. Well, wouldn't the equivalent then be 0.05 of estradiol to equal preventing those diseases of menopause and the bone protection and that? Is that what you understand, or what do you?
Well, I kind of view the whole picture a little bit from a different perspective. First of all, I don't really care what dose a woman takes, of whether it's a transdermal patch or a cream or a capsule or a tablet. Really, the dosages of Premarin are completely made up. The 0.65 doesn't mean anything. It doesn't mean it has 0.65 milligrams of any particular hormone. They made that up.
Okay.
It's based on a percentage of how much estrogen is in there totally, but the actual dose of Premarin doesn't have anything to do with the number.
Okay.
It's old school thinking. What I am much more interested in is trying to get to optimal blood levels. Now, I know there's a lot of controversy among a lot of providers about blood versus saliva versus urine testing, maybe some other types of testing. I would say that serum or blood testing has the biggest amount of evidence backing it up by far. And what we can see is, if we look at women in childbearing years, we can kind of see this peak and trough over the course of a woman's menstrual cycle. And what we do is we can kind of look at the average. It goes up really high, maybe it goes up to 400, and maybe it goes down to 60, and it goes back up to 400. But on average, if we draw a line through the average, it's about 100. And so that's based on what women have for decades, from the time they're 12 years old up to the time they're 52 years old. So 40 years, they have this up and down, but on average, they're getting about 100. I think the units are picograms per milliliter. And so that's kind of a target that I would love to see women get to. There is a little bit of a practical issue with estradiol, and that is estradiol is very regularly known to cause some breast tenderness. And so a lot of women, if we're trying to get up to 100, they're going to tend to struggle with breast tenderness. And so We may not get up to 100, and we may get to 60 or 75, and that's okay, if we're in that ballpark range. If we push them up to 90, they get breast tenderness, and bring them back down to 70, they're okay. So that's what I would consider to be an optimal estradiol range. The same goes for progesterone. Optimal progesterone level would be maybe around 10. If we can get there, there may be some practical limitations. So I'm really less concerned about the exact dose that they're taking. There may be, but there are some significant differences among women in the way they metabolize hormones. So one woman, basically the hormones are, they're out of her body right away. And another woman holds on to them and doesn't metabolize them nearly as fast. And so those two women need different doses because they handle those hormones differently. And that's common, but it's also something that a lot of providers don't really pay much attention to. This is there's a whole area of pharmacy that's exploding now. It's called pharmacogenomics, and it's about the genetic, the genetic codes that have basically been built into our DNA that allow us to metabolize drugs and hormones vastly differently from one person to the next. And we've never really paid attention to that until now. We're just barely starting to. But it's a hugely important thing. But if we look at the other end and we look at like what's that person's blood level, that's maybe a better way to look at it rather than just caring about the dose. So here's another example. A lot of women, when they start taking estradiol, they get bleeding issues. And so the solution to those bleeding issues is progesterone. And sometimes what they need is a higher dose of the progesterone. And if that doesn't work, maybe we need a little bit more. And maybe we need a little bit more. My wife actually takes 400 milligrams of progesterone because that's the dose that works for her.
Okay.
People go, oh my gosh, that's so high.
Right.
Well, that's the dose that works. And so we're less concerned about the dose, and we're more concerned about the overall blood level and the effectiveness in whatever it is that we're trying to treat, if that makes sense.
Yeah, no, you're right. So how would women know that it's working for them, or how they're metabolizing it without doing something like the Dutch test or a urine metabolites test? What are your thoughts on that?
Okay, so I used to live in Oregon. My wife and I moved to Oregon. We lived there for 2.5 years. We lived in a little town called Sherwood, which is about 25 minutes away from McMinnville, which is where the Dutch test lab is. A guy named Mark. What's Mark's last name? There's a biochemist who has developed this Dutch test. And so I went out to his lab and visited with him for an hour and talked to him about the Dutch test. The Dutch stands for Dried Urine Test for Comprehensive Hormones. And it is a very specific type of test that looks at a lot of metabolites of different hormones. And he has some evidence behind it. And he's kind of positioned sort of as opposed to blood testing or saliva testing, especially, and other types of tests. And I find it a very fascinating test. It's maybe kind of a niche test. It's maybe good for certain situations or certain, maybe a woman who's having an unusual reaction to something, or maybe it might be interesting to find out what was happening with a woman that had progesterone intolerance for her to get a Dutch test and find out how she's metabolizing progesterone. I probably wouldn't necessarily recommend a Dutch test for every woman. Tends to maybe be an added cost, an added expense. I don't know, they're $300-400, something like that. And it may or may not be helpful for everybody, but in those, kind of special cases where you're just trying to figure out what's going on with that woman, that's where a Dutch test might come in handy. Now I have a relationship with another doctor, Dr. David Rosensweet, and he has a program that he calls the Menopause method, which is quite interesting. And he uses a 24-hour urine collection test, where basically you take urine samples over 24 hours. And so it's, instead of a snapshot of just one time, you see kind of the overall kind of daily rhythm, which might also have some advantages. There are all kinds of different ways to test. The main thing is to kind of have a provider who really knows what they're doing with the test that they use, right? So if you use serum testing, then I'm hopeful that you are really familiar with serum testing, blood testing. If you use Dutch testing, maybe you understand how to interpret those results. And that's really the key, is having a provider you can trust.
Yeah.
You can get some of these blood tests on your own, order tests for yourself. But my suspicion is you're going to get your test results back and go, oh, I don't know what this means.
Right.
So it's important to have somebody who does know what it means, who can help guide you through it. And what do we do with those results?
Right. And I think it's important that what you were talking about, optimal levels, that women shouldn't be afraid to go up on their dose, because they are a little afraid just based on what they've heard. They still feel like, oh, but actually, if you have some bleeding, that's all normal within the first 6 months or so. I mean, it's not a concern. And honestly, hopefully your provider would never do something unsafe. So, educated ones. But another question I get about hormone therapy is, real quick, we were talking about invisible benefits. Can you talk about real quick the benefits on something like ApoB, cholesterol, and that with hormone therapy and inflammatory markers and that kind of thing, just so women understand the benefits?
Yeah, it's pretty clear that after age 50, both men and women start to develop what are called biomarkers that are going in the wrong direction. And when we talk about biomarkers, a lot of people think about, oh, my cholesterol is high. And that's, that's kind of old school terminology. We don't really look so much at cholesterol exactly. We've looked more deeply, and we've looked at LDL cholesterol. And now I made a whole video, and it's actually the most viewed video that of all my videos. It has 200,000 views. It's about ApoB, or the long name is apolipoprotein B, which is kind of it's a better way to look at heart risk through your blood lipids, or the fats in your blood. And it's an extremely kind of accurate indicator of the heart risk that you might have. So as we get older, what happens is those heart risk indicators start to creep up. So ApoB is one of them. C-reactive protein is a common one. That's an indicator of how much inflammation we have in our bodies. Another indicator is there are several numbers that look at our insulin resistance. And insulin resistance is something, all of these tend to go up after we lose our hormones, men and women. With men, it tends to be kind of a gradual thing over 10 to 15 years. And so it's not nearly as dramatic as women tend to go, they're starting to go down for 6 years, and then they go boom, right at age 51, 52. And what you see is when women have estradiol that's been optimized after they go into menopause, we see an improvement in what's called HDL, or high density lipoprotein. We see, and I'm doing some research on how much their low density lipoprotein, or ApoB, improves, but there is some indication that it does improve. There is some indication that insulin resistance improves, and inflammation improves. So these are some more of, like what you mentioned, the hidden benefits of optimizing your hormones, that you can see a lot of these markers, maybe not like dramatically improve, but subtly improve, and they're going in the right direction. So there are lots of other factors. There's diet, there's exercise, there's lifestyle, there's smoking, there's alcohol, there's all these other things that can have an impact. And so it's not just your hormones, but they're a huge part of it. And so having optimal levels, especially of estradiol, can make a difference in a lot of those biomarkers.
Yeah. I want to talk a little bit about belly fat and insulin resistance in a minute, maybe some testosterone. But real quick, another question I think it would be great for women to hear. I get a lot, we're talking about all these wonderful benefits of hormone therapy, but then they're outside of that window of hormone therapy. The guidelines say within 10 years of menopause or under 60, benefits outweigh the risk, right? But then women who've kind of missed that window are often discouraged that maybe it wouldn't be good for them. So what are your thoughts? When is hormone therapy, in your opinion, too late to receive?
I've made a couple of different videos about this. I'm gonna pull up something. I just was finished writing a YouTube video. I'm going to be posting that this week.
Okay, awesome.
And it is about, I got to get the title right. This study came out on April 9th. Today is April 17th. The title is called Use of Menopausal Hormone Therapy Beyond Age 65 Years and Its Effects on Women's Health Outcomes by Types, Routes, and Doses. It's a brand new study
I saw
that
that.
is all about 100% about women over 65. And I found the results quite encouraging, quite fascinating. And it talks a lot about the perceived notion that over 65 hormones are dangerous and you're going to get all these diseases and it's just bad.
Right.
So I've had so many women come to me and say, my doctor said I'm 65, I have to stop, or I'm 65 and I can't start hormones. I don't believe that for a second. I believe that there are health risks. And as I mentioned a few minutes ago, between age 50 and age whatever you plan to start hormones, those health risks can increase, especially heart disease, but also osteoporosis and insulin resistance and all the others. What we have to do is we have to look at each individual patient. We have to determine, okay, how good of a candidate is this person for hormone replacement therapy? This isn't a blanket statement saying 65 is the cutoff or 60 is the cutoff. That's the wrong way to look at it. What we need to do is say, okay, this woman has maybe some heart risk. We need to maybe tread carefully in some aspects. This woman's heart risk, I have a really good friend of mine and my wife's. I did some coaching with her a couple of months back. And what she's discovered, she's 60, but she had a pretty full evaluation and her heart risk seems really good. And she's getting her hormones optimized, kind of aggressively because her heart risk is pretty good. That may not be the case for every person, but it's not about the exact number. It's about where is that person's risk. And it's also about working with a healthcare provider who really knows what to do with those risks and how to treat them and how to minimize those risks going forward from age 65 to 75 to 85. So this idea that there's a cutoff is just, it's way too simplistic black and white thinking, and it's not looking at the patient. It's looking at the number, not the patient.
Right. Right. Yeah. Thank you for clarifying that. I saw that article too, and I was like, yes, because it's just these women are being taken off of their hormones, and then they lose all of the benefits pretty quickly related to bone loss that they achieved on the hormones. So I think I'm so glad that it's all coming around and we're learning so many things. I always tell my patients, it's a great time to be alive for a woman. We are learning so many wonderful things, right? But about that, all of that recent literature, I think we might want to talk briefly about that new, that Lancet article that was over medicalizing menopause. What were your thoughts on that? I would love to hear it.
I almost blew my top.
Yes.
I'm like, oh my gosh, I can't believe this.
Right.
I can't remember all the things that it was actually kind of a series of articles.
Yeah, like 5 or so.
And there were multiple things that really upset me. Number one was the idea that we're over medicalizing menopause, and menopause is not a disease. And well, we can have a debate about what a disease is, but essentially diseases have symptoms that maybe interfere with your life, and menopause has symptoms. So it's probably not a disease, but it acts like a disease in some ways. And just because we want to call it not a disease, does that mean we should not treat it? Right. And how should we treat it? One of the things that came out, I didn't read this specifically, but I've seen some other people talking about it in the Lancet articles, was something about cognitive behavioral therapy, or basically talk therapy, being a valid option for helping with menopause. And I'm like, my wife and I go to a counselor. We did 2 days ago, and I love my counselor, my therapist.
Yeah.
But that's not going to help me with menopause. Because the problem in menopause, and this is the number one thing that really burns me up with the articles and the whole perspective in the Lancet. There was a line in the Lancet articles that said we need to not look at menopause as an endocrine deficiency.
Right.
Because that disempowers women. And I'm like, the problem in menopause is not the hot flashes. It's not the vaginal dryness. It's not the insomnia. It's not the mood swings or any other of 30 symptoms. The problem is the loss of your hormones. it is an endocrine deficiency. It is not a deficiency in vitamins or yoga
Right.
or exercise or sunshine or vitamin D. It's not a deficiency in any of those things or
Right.
antidepressants or Paxil or Zoloft. It
Right.
is a loss of hormones. And miracle of miracles, when you put the hormones back, the problems go away. That's
Right.
my whole point.
Right.
They
Right.
they are eliminated, and this is it's not magic. It works. But when
Yeah.
we encourage people to not think about menopause as a hormone deficiency, we're telling them exactly the wrong thing. It's
I agree.
is a hormone deficiency, and what we need to do is treat it that way. There is one solution to the root problem in menopause, which is the loss of your hormones. And the solution is replacing your hormones and optimizing your hormones so that they are at optimal levels. And the research is overwhelmingly positive about that. Now, are there studies that say this happened or that happened or this disease increased? Sure. But when you look at the overall picture, studies like the one I'm talking about right here show that hormone replacement and optimizing your hormones is the best thing for women. Interestingly enough, the biggest thing about this most recent study, which came out a week ago, was that estradiol, particular estrogen, overall reduced death from any cause by 20%.
Isn't that amazing?
It's shocking. It's estradiol is an incredibly powerful hormone.
Right.
This is in
Right.
10 million women, a giant
Right.
study.
Right.
20% less deaths on women who took estradiol. That's
Yeah.
incredible. Now,
Right.
there's a lot of subtle nuances to the study, but that's one of the takeaways I
Yeah.
get is hormones make your life longer.
Right.
What this study
Right.
is telling us.
Yeah. And improve your quality of life as well. What I see and hear, I'm on, whether it's a feed or comments or women, I just, our hormones are meant to go low and stay low. So you just need to get through it until your body acclimates to that normal low level. And that's not wrong. Absolutely, our hormones do decline. That's how biology works and how it all works, but we are also living a lot longer and a lot of things have changed. But women can be hard on each other sometimes because I'm going to go through it naturally. So the women that take the hormones feel like, I guess I'm a failure because I'm taking some estradiol, right? It's just crazy what goes on. But when you look at it as, yes, the loss of hormones, we're just giving your body back what it needs to thrive and survive, right? It's just I don't know if men go through that. I think I said that at one point. Do you ever hear a man talk the way that women do about what goes on? No. It's just crazy what we women do.
Well, so I've mentioned this before, but I have a couple of courses that I've made for both men and women. My women's course is 2.5 hours long. My men's is 35 minutes. That's because when you tell men you're going to need testosterone, he goes, okay, how much is it? And when you
Right.
tell women you're going to need hormones, you're like, oh my gosh, I don't know, maybe. I've heard so many things and I'm so afraid and
Right.
I need some reassurance and I need more information. But for men, it's like, all right, sign me up.
Exactly. Right, right. So another thing I think we should mention real quick, because I do want to talk a little bit about testosterone, is the genitourinary syndrome and menopause and how important it is to initiate local low dose vaginal estrogen early because those symptoms are progressive. So maybe talk a little bit about that and how safe it is and why all women should be doing this at a certain point.
Yeah, vaginal estrogen is something that really helps with vaginal issues. And so there are multiple issues that happen
Mm,
because the estradiol level is low in the vaginal area. One is vaginal dryness. Painful intercourse is very common in menopause. And frankly, this is affecting a lot of marriages, and
mhm,
wives and husbands are both dissatisfied and they're disconnected physically. And it's causing some major issues.
mhm.
Um, Not only that, but also their urinary tract infections are much more common in women in menopause, partially because the vaginal tissue has a lot less estradiol. Now, one thing that you've kind of alluded to a couple times is these are progressive. So I'm talking about this in my next video, and that is a lot of the symptoms of menopause. Well, I won't say a lot. A few of the symptoms of menopause, maybe 4 or 5, may tend to get better over time.
Mhm.
Hot flashes, which is kind of the classic symptom that everyone thinks of when they think of menopause. Hot flashes, there are some studies that show maybe 7 years for Caucasian women, maybe 9 to 12 for Hispanic and African American women.
Mhm.
But at some point, theoretically, a lot of women will have those kind of decline and there'll be less of a problem. That's not always the case. There are some women who have hot flashes 20 years after they go into menopause.
Poor
But
thing.
a lot of women do have decreased symptoms. Genital and urinary symptoms of menopause tend to get worse and worse and worse over time.
Yeah.
And I have had a couple of messages in the past couple of weeks that have been just heartbreaking, talking about something called prolapse.
Yeah.
And I recommend in my video, do not Google prolapse. You don't
Right.
know
Right.
what it's about. But the
Right.
PG-13 version is that your lady parts fall outside of your body.
Right.
And it's
Right.
just horrifying. I had a
Horrible.
woman who emailed me just the other day, and she said she was terrified to tell her husband because she knew he would freak out. And I'm saying, if my wife came to me and told me she had a prolapse, I'm freaking out because this is an awful, awful situation.
Right.
And
Right.
I'm not saying that, if you don't take hormones, you're going to have a prolapse. That's not what I'm saying. I'm saying that's the worst case scenario. It's possible,
Right.
because these symptoms get worse and worse and worse. And I'm thinking of some women that I've known in my family that lived to be 100 that were completely incontinent by the
Yeah.
time they were 100 and wore Depends all the time. And one of the reasons is because of the lack of estrogen, the lack of vaginal estrogen.
Mhm.
And this is a major problem. But no one
Right.
talks about vaginal prolapse, and no one talks about urinary incontinence issues as you get older because it's embarrassing, humiliating, and
Right.
horrifying.
Right.
Um, but it is a major issue that we
Mhm.
need to address. And the simplest way to address it is by low doses of vaginal estrogen. Now, I also have some information about vaginal DHEA, which
Right.
has also been used for some of the vaginal symptoms of menopause. And it doesn't even have estrogen. It is converted to a very small degree to estrogen in the vaginal tissue.
Mhm.
But there are options. Um,
Mhm.
if a woman is afraid of estrogen, she shouldn't be, but if she is, she should recognize that very little estrogen is absorbed into her bloodstream, her overall system, when she takes a vaginal form. Now, that also means it's not going to help with a lot of overall body symptoms like hot flashes or mood swings or irritability, those kinds of things.
Right.
But it will help with some of the vaginal issues of menopause. And
Yeah.
so it's definitely an important part of optimizing your hormones,
Right.
optimizing the estradiol in the vaginal area.
Right. And some women, most women, it's okay to get the systemic patch and do the local estrogen because the systemic patch doesn't always help down there. So both are safe and both are needed.
It,
Um,
it's
be-
often necessary to use both because it's not enough to just have the systemic patch. And
yeah.
you may still have some vaginal dryness issues and urinary tract infections and that kind of stuff.
Yeah. I've had a little bit of trouble getting the DHEA covered by insurance. I don't know if other providers have had that problem.
Yeah.
Um, but yeah, I don't know why. It's like it's another thing. It's been shown to improve vaginal dryness, sexual function, all of that. So, um, definitely. Anyway, let's talk about a little bit about testosterone.
Okay.
Why do women need to know about testosterone and the best way to get it and why it's so important?
So a lot of people don't realize that testosterone is actually, I think it's somewhere around 100 times more testosterone in women's bloodstreams than they have estrogen. It's not as much as men, but it's still 100 times more than their estrogen. And testosterone is incredibly important. Number one, it helps with sex drive or libido. Number two, it also helps with bone density, bone strength. But most importantly, it helps with muscle strength and muscle mass. And this is a problem that I've really been emphasizing in the last several months or a year, mainly because my dad is 86, and he is the weakest person I know. He can barely stand up. He can't take a single step without his walker. It takes him 5 minutes to get into the car because he's weak. And this is incredibly common problem in both men and women. It's called frailty. And we lose about 1% of our muscle mass every year. So if you start losing muscle mass in your 40s and you go down 1% over 40 years, by the time you're 80, you've got no muscle left. And so that's why you end up with a cane, because you can't stand up, you're wobbly. You end up with a walker because you can't get up out of a chair without assistance. You end up in a wheelchair or in a nursing home, or you end up falling and breaking your hip. And it's all goes back to the root problem. Number one, you haven't had enough exercise. But number two, you haven't had enough testosterone. Your testosterone is really helpful. It's called an anabolic, which means building up. Anabolic steroid. It helps you build muscle primarily. And when you don't have that testosterone, you're just not as able to build muscle and bone. It's just so hugely important. The other part of that, exercise, testosterone, and protein, adequate protein levels are all the three pillars that help us avoid osteoporosis or weak bones and sarcopenia, weak muscles. And I have this personal experience of reaching out and catching my dad when he's about to fall over. My dad has fallen 6 times in the last year, and it's a miracle that he hasn't broken something, because he also has osteoporosis. My mom fell and broke a hip because she has osteoporosis, and she was never on hormones because she didn't have any menopause symptoms. And so, I don't need any of that stuff. I'll be fine without it. She's paying the price now in multiple different ways.
Oh, wow. You know what? You are so right. I hear that all the time. And that's why, going back to those invisible benefits, I hear that all the time. I don't have problems with hot flashes. I don't have problems with any of that. I'm fine. I'm thinking the underlying processes are still going on. We have to think about this. Another thing with women and testosterone, they don't realize it helps with difficulty concentrating and mental clarity and even confidence. But let's talk about the route. How do you feel about pellets? And is transdermal through the skin just as effective when it comes to testosterone?
I have kind of struggled to find the most solid evidence. What I'm always looking for is a really good clinical trial. The one clinical trial that I'm really interested in is one that looked at, it's called the Dayton trial. And it was a few years back, maybe 10 years ago. And they basically gave women pellets underneath the skin. A lot of times it's in here or it's in their hip. A subcutaneous pellet that's left in there for several months. And what they found in this study was that they had a 38% reduction in the number of breast cancer cases, which was astounding. That testosterone, we're kind of guessing that there might be a causation. It's an association, but there may be a causation involved there. But if that's the case, that's a pretty huge drop in breast cancer risk because of testosterone in a pellet. Now, there aren't honestly very many studies about testosterone in women. I have another study I did a video about, which was about testosterone patches for women. That was mainly about low sexual desire, and the patches were definitely an improvement for sexual desire. And so that would kind of hint that, say, a transdermal cream would probably behave similarly to a patch. Maybe not identical, but there should be a lot of significant differences or significant similarities between the patches and a cream. But honestly, the research is kind of lacking as far as women in menopause, especially, receiving testosterone and what the best forms are. I would probably generally lean towards transdermal creams, there really isn't a commercially available form of testosterone.
Mm.
There are forms for men, and I've heard several providers, doctors on Instagram and YouTube
Mhm.
saying, well, just take a men's dose and cut it down by 10.
Yeah.
And well, that's a nice idea, but as a compounding pharmacist, I can tell you, first of all, when you take, let's say, take a patch and cut it into tenths, it's not going to work. Second
Yeah.
of all, you take a gel that comes in a foil package, you tear it off, and you're like, how do I get a tenth of this? It's like
Right.
everywhere, and the practical issues are
Yeah.
they're impossible to overcome, as far as I'm
Yeah.
concerned. Now, there may be injections might be another option. You can use a very, very small injection for women,
Mhm.
maybe a
Mhm.
tenth of a dose. It's, it's not the
Mhm.
easiest thing to do, but it is
Mhm.
possible.
Mhm.
So in my somewhat biased opinion, I would say it's best to use a compounded testosterone that is a dose specifically designed for women.
Yeah.
Um, a lot of people are opposed to compounding it for lots of reasons, which I won't go into right now. But that's really the most practical way for women to get testosterone, at least in the United States, where there is no FDA approved, commercially available testosterone product for women.
That's what I do. I use a compound pharmacist. They put it in a clicker so women know exactly how much they're getting, how much to use, and have had great luck with that.
Yeah.
I know there's all these different things. I think that, like you said, with men, pretty straightforward. Boom. With women, is it natural? Is it bioidentical? Is it this? Is it compounded? It's like, oh my goodness. It's a lot. Real quick, talk a little bit about how testosterone impacts belly fat. Women have it's complicated. Insulin resistance increases, but I thought or read or something that testosterone may worsen insulin resistance, but yet I don't know. What is your research on that?
Yeah, I haven't been able to find a ton of really conclusive. There's no study that I'm like, oh, I got to make a video about this because this is exciting, positive news. I
Yeah.
haven't found that study just yet.
Okay.
I would say overall, if you have all of your hormones optimized, especially your estradiol and your testosterone, you're more likely to reduce visceral fat. And visceral fat is bad,
Yeah.
basically across the board. Now, people think about, okay, I have a fat belly. But there are two different reasons why you may have kind of fat around your midsection. One reason is called subcutaneous fat, and that's the fat right underneath your skin. The other reason is visceral fat, which is fat inside your abdomen that you can't really touch with when you push on your belly.
Yeah.
It's fat that's around your liver and your kidneys and your spleen and all of the organs inside your body. That is fat that basically causes inflammation in your whole body. It opens you up to insulin resistance and type 2 diabetes. The worst type of fat is fat around and inside your liver. That's called non-alcoholic fatty liver disease, which is an incredibly common and incredibly dangerous problem. It basically means you are far down the pathway of insulin resistance and
Mm.
you are open to a lot of major diseases, most notably cardiovascular disease, heart disease. And your liver is not going to be able to handle that very well either. So you could be open to
Right.
liver disease and a lot of liver issues.
Right.
So optimizing all your hormones is really the key, along with exercise and proper diet and that kind of thing. You need to do all of these things in order to minimize that visceral fat, because visceral fat is always a bad thing. You don't want visceral fat. You want to get rid of it as much as possible. Now, interestingly enough, visceral fat does produce some estrogen. Visceral fat often produces some estrone. And so a lot of people who have a lot of visceral fat might not experience hot flashes because they have a little bit of estrogen that's coming from that fat. That's not necessarily a good thing, but
Yeah.
it kind of masks some of the symptoms of menopause, and they
Mm.
may feel it like they're doing fine because the symptoms of menopause have kind of been kind of tamped down because of that
Mm.
visceral fat.
Mm. Well, that makes sense.
Yeah.
Speaking of liver, um, I get a lot of questions about oral estradiol versus transdermal estradiol. Some people are totally against oral. because of the clot risk, and it's just back and forth. So women are often confused by that. What are your thoughts on oral versus transdermal? You feel like they're both safe?
I do. Um, Now, there is a lot of controversy, and basically the conventional wisdom among the vast majority of hormone providers is that transdermal estradiol is hands down the safest way to go.
Mm-hmm.
That's a perspective. It's a perspective I don't necessarily 100% agree with. My wife went to a pharmacy that I used to be associated with just in the last couple of months, and the pharmacist basically said, "Oh, well, we don't do oral estradiol because of the teaching of this particular teacher. We only do transdermal." And my wife is like, "Well, I take oral, so bye. Good luck." Um,
Right.
but the theory is that oral estradiol goes through the liver. It's called first pass metabolism, and the metabolites of estradiol uh, increase the clotting potential for some people. Now, this is really based on studies primarily about conjugated equine estrogens. Those are estrogens that come from horse urine. The brand name was Premarin, and that was the one that was used in the Women's Health Initiative study. So there are a bunch of studies that show that Premarin, or CEE, increases clotting risk when given orally, especially in women who have maybe an elevated risk for blood clots. Maybe they've already had one of two very dangerous types of blood clots. One's called a pulmonary embolism, and another one is called a deep venous thrombosis, so PE or DVT. And if a woman has had one of those two, or she has a particular genetic risk factor called factor V Leiden, maybe some others, then that woman may be more likely to get a blood clot. And there is some evidence that this horse estrogen has increased blood clots to some extent in some studies. Now, when we take a step back and we look at estradiol, what we find is estradiol is a lot cleaner, a lot less contaminated than the horse urine estrogens. And the studies just are not very strong. They don't really show estradiol as increasing clot risk. There just are not very robust data that show estradiol increasing clot risk. It's probably a good idea to be aware if a woman has had a clot. Okay, maybe she shouldn't be on an oral form of estradiol or Premarin. If she has factor V Leiden or some of these other clotting issues, if she starts showing some signs of clotting, those would be situations where we might, kind of step back and not want to give a person oral estradiol.
Mm-hmm.
But on the other hand, we have at least two studies. One's called the Danish Osteoporosis Prevention Trial, or DOPS, and the other is called the ELITE trial, the Early versus Late Intervention Trial with Estradiol. Both of those used oral estradiol, and both of those showed a significant reduction in cardiovascular risk. Those were pretty dramatic improvements in cardiovascular risk, especially for women who took estradiol early in menopause. We don't have any strong studies like that showing cardiovascular risk prevention for transdermal estradiol, at least not as strong as those.
Yes.
So it's one of those, we have to weigh it out. Okay,
yeah.
There may be a risk of blood clots, but this type of estradiol has really been shown a lot more strongly to reduce cardiovascular risk. Again, getting back to the number 65, you're done.
Yeah.
You start over 65. Let's not look at it in those terms. Let's not say, well, everybody has to have transdermal estradiol. Let's look instead at each individual woman and say, okay, what is this woman's relative risk for blood clots? Have they had a DVT or a PE before? Are they likely to benefit from something that reduces their cardiovascular risk? Let's look at the overall picture. That's the reason why every video I have just about encourages women to find a hormone optimization specialist like Kim, who really understands your risk and understands what to do with your risk and understands how optimizing your hormones fits in with minimizing your risks and maximizing your benefits.
Right. Yeah. I literally just commented to somebody who was kind of going off on oral, and I said, well, honestly, there's research that shows It has better cardiovascular protection. So I typically start with transdermal though. And if it doesn't work, there's all different reasons, or maybe it doesn't get them up to, then maybe consider oral. I mean, you can't be afraid of it. That's right. Is there anything I didn't ask you that you wish I would have, or you wish I would have addressed, or you want to talk about anything?
Oh, I could go on for hours. Hang on just a second. Let me quickly look at my notes. Oh, I gotta minimize your screen so I can see them. Blood clots. Yeah, I think we've covered the vast majority of what maybe we ought to talk about. What are we doing? How are we doing on time? It's been an hour and
Yeah,
a something.
it's yeah. I know when we get to talking about hormones, it's such a big topic though. We've covered so many grounds. Well, if you had a billboard that all women would see, what would you want it to say? What would you want them to know?
That's an interesting question, and I think if I had a billboard that I didn't have to pay for, what
That's
I
right.
would say is something like confused about whether hormone replacement therapy is right for your menopause or not. I can help you make that decision in about 2 hours, and it would be about my course. I have a course that I call the Menopause Solution, and it's really designed to answer that seemingly simple question:
Mhm.
Is hormone replacement therapy, or HRT, right for my menopause or not? And
Mhm.
I'm going through multiple different things. The structure of this course is based on three kind of pillars. One is about searches. What are women actually typing into Google and asking Dr. Google
Mhm.
about hormones and menopause? And then what I'm doing with that is I'm looking at those questions, and I actually found out what are the most common questions that get on Google. And
Mhm.
what I'm doing is answering those questions in a way that you won't get those answers if you actually go to Google, because there's advertising and there's a lot of biases and there's a lot of
Mhm.
things that are interfering with understanding the truth. There's a lot of the misleading information that we already talked about early in our
Right.
conversation. And so what I'm doing is answering those questions from a perspective that really shows you the truth that you may not get when you search Google. The second part of my course, the second kind of pillar, is about stories. I'm telling the stories of a lot of women in menopause to help you know, number one, you're not alone. And
Right.
number two, there is hope. And these stories kind of, I can share thousands of them, but I
Mhm.
share a few
Mhm.
that help you understand those two principles. And then the third kind of pillar in my course is all about studies. And I've talked a lot about that in our conversation, but I
Mhm.
want to look very closely at the evidence. I want to be empathetic. I want to look at, your fears and your concerns, and I want to
Mhm.
deal with those empathetically, but I also
Mhm.
want to bring you the evidence from the medical literature, from
Mhm.
the science. What does the science actually say? Things like the Women's Health Initiative that we've talked about.
Mhm.
So I have this course that I put together, and I've been working on this for multiple years. It's kind of
Mhm.
like, I feel like it's my I call it my magnum opus, my great work. It's
Oh,
the thing that I am supposed to do, and I can't
yeah.
not do it,
Yeah.
because so many women need to answer this question: Is
Mhm.
hormone replacement therapy right for my menopause or not? And so that's what the whole course is designed to do. Um,
I think women should take your course. I always say this. Well, first of all, women often make decisions for themselves based out of fear, and they miss that very can be very detrimental to your health.
right.
And I always say an informed woman is an empowered woman. Know, get informed, get educated, know your options, and then find a provider that will help you. And if you go to a provider and they say what I've heard many, many times, I don't prescribe hormone therapy. Well, then you need to find a different provider because, first of all, there's medical guidelines that help guide you into doing it. Um, but definitely take the course, get educated, and know your options, and then take that to your provider.
Right, right.
Right. Yeah.
Absolutely, 100%.
Steve, direct everybody to your website and your awesome YouTube channel. Simple Hormones is great. And yeah, where can everybody follow you?
Okay, so as Kim mentioned, I have a number of places where you can find me online. Probably the easiest place is at my website. And what I've done is I've created a special page, especially for women in menopause. If you go to simplehormones.com/Kim, just Kim.
Easy.
That's a special page where I'll give you a peek at my menopause course, and there's a special discount there. And Kim and I are kind of partnering together on it. So that's a place where you can learn all about that particular course. If you just go to my main website, simplehormones.com, you can see all of my other stuff. I have a lot of stuff on that site that's really designed for healthcare providers, but there's also a place where you can, if Kim is not your provider, you can find a referral to a provider in your area. So those are two options, simplehormones.com. And then if you want to look specifically at the course, simplehormones.com/Kim. Now, if you would also like to take a look at my YouTube videos, what I would suggest is that you go to youtube.com/@simplehormones, or you can just type in Simple Hormones in the YouTube search. And then I'm actually working today on my 99th video.
Wow.
We'll have 100 videos, hopefully by next week. And my 100th video is going to be a fascinating one. It's one that's just kind of blasted me in the face. It's about endocrine disrupting chemicals. And that is a topic that is absolutely terrifying, but it's going to be
Good.
to understand about.
That's
So,
awesome. Yeah, I'm looking forward to that one. That is so important. And there's new research coming out about it. So
tons.
Good for you. Thank you. Thank you for being here. Your knowledge is incredible. Thank you for your time and the resources and everything that you offer. And I hope everybody takes the course because you have dedicated so much of your life and so much effort putting into it. So thank you so much for being here.
All right. You're so welcome. And we'll have to do this again, Kim.
Absolutely.
So
anytime.
Fun. I never turned down an opportunity to geek out about hormones because my friends are from the menopause, man, right?
Yeah, that's right. Me either. Awesome. All right. Well, have a great day. Thank you so much again.
All right. Thanks, Kim.
Thank you.